each one of you is important program where our sir, Dr. Apurba Ghosh, the director of ICH, will give the speech. And we are the maker of Prevener from Pfizer Limited. Thank you for your kind participation. Please, sir, you can go ahead.
তোমরা তো বাস স্ক্রিন শেয়ার করবো?
হ্যাঁ স্যার করুন। ইন্দ্রাণী তুমি মিউট হয়ে যাও, ভিডিও অফ করো।
এবার কি করব? এইটা না,
শেয়ার স্ক্রিন, স্লাইড শো।
এটা যে আমার কাছে যে স্ক্রিনের মধ্যে যেটা আমার স্ক্রিনে এসে পড়ছে যে আমার সেটা তোমরা ওকে। Should I start?
Yes, sir.
Yeah. Good evening, everybody. First of all, I thank Pfizer India Limited for sponsoring this program, the makers of Prevener 13. My topic is pneumonia and its prevention. I dedicate this lecture to my teachers, of whom I'm very, very proud. I'm very proud that I worked with Dr. Ghosh, who drove Netaji when he was just 20 years, 11 months during his great escape, when he was just a third-year medical student. He was also the first editor of Indian Pediatrics and the convener of the Constitution Committee of Indian Academy of Pediatrics. This is his birth centenary. I'm also proud of my MD guide and professor and head of the department during my stay at ICH as a student, who was the president of Indian Academy of Pediatrics 1980. Incidentally, this is also his 100 years birth. And of the very few Indians who has the disease in their own name, Dr. S.P. Ghoshal is one of those. The Ghoshal hematodiaphyseal syndrome is included in the Oxford Medical Database, of which I was one of the co-authors. And then Dr. A.K. Dey, under whom I worked, the man from whom I learned the punctuality and also the pediatrics. 9 o'clock sharp, Dr. Dey will be there. Coming to the pneumonia, the global under 5 deaths from 5 infectious diseases like pneumonia, diarrhea, malaria, measles, and AIDS, you can see that the pneumonia tops the list. But over the years, this disease has decreased. The lower respiratory tract infection from 1990 to 2015, you can see there is a sharp decrease in lower respiratory infection, and thanks to the immunization practices that we do. Now, Streptococcus pneumoniae is an important cause of death amongst those deaths that I have shown you. That the 11% of the death in under 5 children are due to Streptococcus pneumoniae. And amongst all the respiratory deaths, 41% were attributed to Streptococcus pneumoniae. So you need something to prevent this, to decrease the mortality in children under 5. In 2000, almost 600,000 deaths due to pneumonia, pneumococcal disease, and this declined by 51% to 294,000. So you can see there is a marked reduction of pneumonia death in 15 years. And as I said, that it constitutes 11% of all deaths in children under 5 years of age. Now, what has happened over the years? See, the PCV7 was introduced in the middle of 2000, and after that, there is a sharp decline in the pneumonia incidences. But also what you need to know is that as the pneumonia decreased due to the strains containing the PCV7, there was a sharp, mild increase in 19A in pneumonia, and that is called serotype replacement. What happened in Canada, that after the introduction of PCV, there was again a sharp decline in all serotypes, especially the PCV serotypes. As you can see, it has decreased a lot, but there was decrease in all other serotypes also. Now, in India, with the current vaccines, we have two types of vaccines. One is PCV10 and PCV13, which contains 19A, 3, and 6A as an extra over the PCV10. And so the PCV10 covers protection against 67.3% of the invasive pneumococcal diseases, whereas PCV13 covers 78.4%. So there is almost an 11% increased protection with PCV13. And as you know, there are more than 90 different pneumococcal serotypes have been identified. Serotypes 4, 6B, 9B, 9V, 14, these are the important ones. And this covers 60 to 80% of the infections. These are the three which is absent in PCV10 and present in PCV13. Now, in the United States, between 1998 to 2016, the overall incidence of IPD in children below 5 years declined from 95 to 9 cases per 100,000, but this PCV13 serotypes has declined from 88 to 2 cases per 100,000. So you can see there is a marked decline. As in this graph, we see that the PCV7 was introduced here in 2000 and PCV13 was introduced in 2010, and it has really decreased the incidence of invasive pneumococcal disease. Now, this is the study which is called PARCH study funded by Bill and Melinda Gates, done in 7 countries. 1 to 59 months age, bacteria is 27%, virus is 61%, fungi and otherwise not otherwise specified is 5%, and tuberculosis in 6%. Now, this is the one that the virus is 61% and bacteria 27%, fungi and TB. Now, these are the top 10 causes of severe pneumonia in children. You see the RSV tops the list. Then the other viruses like rhinovirus, human metapneumovirus, parainfluenza, and influenza. The tuberculosis is 6%, as I have told you. H. influenzae and staphylococcus and pneumococcus are the 3 important players in the bacterial etiology. Now, there is no vaccine against staphylococcus. We have almost covered H. influenzae, so this is hardly we see nowadays, and pneumococcus is the one which is preventable. And in the EPIC study, there is slight difference that the Mycoplasma pneumoniae is slightly more than the Streptococcus pneumoniae, but that also includes the children's more than 5 years. What is the position in India? There is a very nice article and study from CMC Vellore, invasive pneumococcal infections in Vellore. And you see that of all the strains, 1, 5, 19, these 3 strains are significant contributors to the cause of pneumonia in CMC Vellore, and that's an national study. And these 3 are present in Prevenar 13. And this is the difference. PCV10, you don't have 3, 19A, and 6A. The PCV15 will be coming maybe in near future, which will have 2 more, 22F and 33F. Now, what's the advantage of PCV13? It contains PCV3, and the PCV3 has a very thick capsule. And serotype 3 has a very thick capsule, and it strongly resists opsonophagocytosis because of its thick capsule. And it causes marked inflammatory response and causes neutrophilic infiltrations and suppurative necrosis. So it's an important cause for necrotizing pneumonia. Serotype 19 is very invasive and it causes multiple antimicrobial resistance. So these are the two important strains which are added in PCB13 and has a great advantage that we have seen. These are the organisms which is common, and according to age, as I said, mycoplasma is usually after 5 years, but Streptococcus pneumoniae, it starts after 6 months, but it is always there all throughout the life. Now, this is a classic X-ray, and this shows the solid consolidation. This is solid lobar consolidation, which is common in pneumococcal pneumonia. And pneumococcal pneumonia is more common on the right side than on the left side. But the problem is, you know, in the first 3 days, first 72 hours, the tachypnea may not be there. So you must have a high degree of suspicion to diagnose pneumonia, because tachypnea, temperature and decreased feeding that we say is the diagnosis of pneumonia is absent. So you need to do a chest X-ray if you think that it might be a pneumonia. Now there is a controversy that whether we need to do a chest X-ray to diagnose pneumonia. I'm not going into that debate now, but this is a classic consolidation and most probably due to pneumococcal pneumonia because this child was not immunized with that. Now, in case of pneumonia, pneumococcal pneumonia, usually they have a single chill, but if it is a staphylococcus or Klebsiella, you will have multiple chills. That you should remember that pneumococcal has a single chill. Now, this is again a pneumonia which is round in shape, and this is called round pneumonia. Now, round pneumonia is usually seen in children below 5 years because of the pores of Kohn and the pores of Lambert are not well developed in children below 5 years. And the most common cause for round pneumonia is Streptococcus pneumoniae, though other organisms, including tuberculosis, can be a cause, but Streptococcus pneumoniae is the important cause. But this is not round pneumonia, and they will not respond to antibiotics. So you need to think of that this is a hydrated cyst, is such a round shadow that you see. So what about the follow-up X-ray in case of pneumonia? It is usually not required, but in case of round pneumonia, or if there is a collapse, or if there are persistent symptoms, one should do a follow-up X-ray to see the clearance of it. Now, after the X-ray, the second most important investigation that we do is the chest ultrasound. In our hospital, our PICU specialist and many others trained under him are very good in doing a chest ultrasound. And it has got a high sensitivity and specificity, and it has got a very good negative predictive value. So it's all over 92, 93%. The chest ultrasound is important, and it is very good technique nowadays we have learned. Coming to the necrotizing pneumonia, other than the solid consolidation that I have shown, the necrotizing pneumonia is on the rise, and of the 116 cases, 59% were due to pneumococci. 190 of the 197 cases, 59% is Streptococcus pneumoniae, and for 23% cases are due to Staphylococcus. And of the Staphylococcus, this is rising. The MRSA strains are rising. If any patient doesn't respond, or if you have got the suspicion of a necrosis, then please do cover with MRSA. This is a necrotizing pneumonia due to pneumococcal, and because in case of Staphylococcus, it is bilateral And in case of pneumococcus, it is usually in the lobe, and this is in the right middle lobe. And the strains that causes 1, 3, 14, and 19A, which are there in Prevener 13. As I said, that the serotype 3 results in necrotizing pneumonia or empyema. I will show you afterwards. And need for surgical treatment. So your vaccine must contain serotype 3. And 19A has a multiple antibiotic resistance. So PCV13 covers necrotizing pneumonia very well. This is again a necrotizing pneumonia, but what you see, it is bilateral. And that's very characteristic of Staphylococcus. You see it's bilateral. Pneumococcal is usually confined to one lobe. Staphylococcus is usually bilateral. And this is not covered with your vaccine. Now, you need to know that Staphylococcus can be a cause. Now, of the necrotizing pneumonia study in 2003 to 4, some are culture negative. Streptococcus pneumoniae is the major player. MRSA is the second, and then it is MSSA and Pseudomonas are the other causes. Now, this is a child. This picture is actually very became well. So this was the X-ray. I will come to the picture that there is a fluid level here. And if your patient doesn't respond within 48 hours, despite appropriate antibiotics, think of that it might be developing a empyema. Now, we all discuss about that the decubitus film. This is just for students, that it is mainly in adult patients that has been studied. It's small effusion. This is a decubitus film. If it is less than 1 centimeter, it is called small effusion. 1 to 2, it is called moderate, and more than 2 centimeter, it is large effusion. But because we do the ultrasound nowadays, this has become obsolete in some countries. And in the upright chest film, when it is covering less than 25%, it is called small effusion. Less than 1/4 is the small effusions, 1/4 to half is the moderate, and more than 1/2 of the thorax is the large effusion. Coming to the CT after that, after the ultrasound, we go for the CT. Now, surgeons has a fixed mind that we need to do a CT before doing the operation. But that's not true. It has been studied by Koren et al. Found that CT scans were least useful in the pre-operative assessment of empyema complicating community-acquired pneumonia. So CT is less used nowadays, but still we have seen many of the surgeons, they say, oh, before putting a drain or putting a pads, we'll do a CT scan of the chest. But the CT scan of the chest is necessary post-operatively if there are complications. It is seen that pre-operative CT scan doesn't add anything extra which is being added by chest X-ray or the ultrasound. But if you have a post-operative complications, CT scan may be useful. If you are doing a VATS, sometimes if there are lesions subpleural, it might be necessary because otherwise you might do trauma to the lungs proper. So sometimes it is necessary, but most of the times CT scan is not necessary. So coming back to the X-ray, as you can see, here there is empyema and there is a consolidation. So let us see what did the CT added in this patient. Because I did the CT in this patient and CT showed that there is empyema and there is a solid consolidation, which was evident in the chest X-ray also. So it didn't add anything. Now you might ask me that why did you do the CT scan then? One of the problems is that ultrasound cannot be done, may not be done at night. But CT scan, the technicians can do, and you can read CT scan better than an ultrasound. But fortunately, next generation pediatricians are getting more and more trained in ultrasound of the chest. So I did the CT scan at night and contacted the surgeon, and so the operation was done next day. Now, at this point, I would like to mention that empyema hospitalization has increased in US children despite pneumococcal conjugate vaccine. Now, this is not only in USA, as you can see that the empyema hospitalization has increased even after the vaccinations. And this is an Australian study where they have shown that even after the introduction of 7-valent pneumococcal conjugate vaccine, there is increased in empyema. What happened in Mexico study is slightly different, that the empyema due to staphylococcus has increased, the empyema due to others has increased, but after the PCV13, empyema didn't increase at all. So that's mainly in Mexico that has been shown that the empyema didn't increase. But the other organisms, staphylococcus, unknown, and as a whole, the empyema has increased after the vaccination. This is fairly a recent study up to 2018. And this is another from Germany. They have shown that the Streptococcus pneumoniae serotype 3 associated parapneumonic pleural effusion or empyema after the introduction of PCV13 in Germany. We don't know the reasons for that why, in spite of covering with Streptococcus pneumoniae 3, there is increase in empyema. But in UK, 62.9% empyema are due to Streptococcus pneumoniae. Type 3 causes more bronchopleural fistula because, as I said, it's very necrotic. Type 1 usually without a bronchopleural fistula, and cavity is more common in 1 and 3. In Spain, type 1 is more common. Very interesting fact. William Osler said, is the standard of excellence and model for the evolution of the profession and its practitioners. We all say the Oslers. But William Osler stated that empyema should be treated as an ordinary abscess with incision and drainage. But unfortunately, Osler underwent a rib resection for his own postmortem post-pneumonic empyema, from which he ultimately expired. What does it mean? That the empyema should not be taken lightly. It is just not an abscess. It is slightly more than that and should be managed. So coming back to the patient again, this patient's empyema didn't respond. So we had to put a tube. So we did a drainage in this case. I will discuss about that whether we should put a drainage or what other options that we have, but we put a drain in this child, and gradually the patient improved, fever subsided, but there was some pleural thickening in this area. So we did an MRI because we have already done a chest CT scan. I didn't want to do the CT scan again, so I did an MRI, and MRI showed a quite serious appearance. We consulted a thoracic surgeon. He said we'll have to do the decortication in this case. But the child was otherwise well, and we were in two minds that whether we should go for decortication or not. The family at that point consulted a very senior chest specialist, and he said don't need to do anything, wait. And we waited, and the chest X-ray got cleared completely. So sometimes it is better to be kind than to be right. At that point, with the MRI, we thought that decortication is necessary. But if the child is otherwise well, we can wait. Because of the plasticity of the children's, lot of problems can be cleared off with time. So how do you manage a parapneumonic effusion in children? The small effusion, no respiratory distress, just treat with antibiotics. If it is small effusion, no respiratory distress, just treat with antibiotics. But if it is moderate or large, I don't like normally this type of flow charts. It's very difficult to understand or to make you understand during a lecture. But I made a summary of that. Small effusions, no respiratory distress, as I said, is conservative. Simple effusion, but not loculated. You can do a thoracentesis with drainage only if it is less than 5 days duration. But if it is loculated and it is more than 5 days duration, then you need to think of that 3 options you have. You can do a VATS, video-assisted thoracoscopy. You can do a fibrinolytic therapy. You can do a thoracotomy. Now, the comparison between these 4 techniques, one is the antibiotics and chest tube only. As I said, the fibrinolytic, as I said, the VATS, and the thoracotomy, or rather nowadays called mini thoracotomy. See, the mortality in fibrinolytic therapy is 0, VATS 0, and thoracotomy is 0. But it can be high if you just put a chest tube. So just putting a chest tube in a complicated pneumonia, in a loculated empyema is not a right option. The failure rate is quite high. The length of hospital stay is quite high. Duration of chest tube is quite long. Duration of antibiotic is also long. And the complication rates is also long. The best treatment, if you have got the expertise, I think is the VATS. In a complicated one is the VATS. Fibrinolytic therapy is still in the process of evolution. In America, they don't use streptokinase or urokinase. The tissue plasminogen activator they use, altiplase they use. In our hospital, we use streptokinase, but giving a streptokinase may be slightly painful, but it doesn't need anesthesia. VATS, as I said, you need an expertise. In our hospital, our pediatric surgeons can do the VATS, and thoracotomy definitely most of the surgeons can do. So that's all about your pneumonia and pneumococcus. But there is another problem with pneumococcus is the hemolytic uremic syndrome. Now, Streptococcus pneumoniae has been reported in 5 to 15% of all childhood HUS cases and 40% of non-cigatoxin cases. So Streptococcus pneumoniae is an important cause. And incidence of HUS in all Streptococcus pneumoniae, invasive Streptococcus pneumoniae, is 0.4 to 0.6%. So if you have a Streptococcus pneumoniae, though less, you always must consider that this child might develop into an HUS. But the interesting fact is that increasing proportion of HUS cases attributable to pneumococcal infection between 1996 and 2016, in spite of having the vaccine. And in spite of PCV13 containing 19A, 19A is the most commonly associated serotype despite the introduction of 13-valent vaccine. While there was no mortality, but the chronic kidney disease complication is quite high in pneumococcus induced HUS. And as you can see in the post-pneumococcal vaccine era, the 19A in many number of cases. So what we can infer from these studies that this vaccine does not give protection against your hemolytic uremic syndrome caused by the pneumococcus. There is another study is that this is a case report where serotype 3 associated streptococcus HUS, which is again there in PCV13. So PCV13 does not give protection against HUS. Coming to this case, this is a 10-month-old female child admitted in July 2018. He had a fever for 3 months, low-grade intermittent fever, and then history of fall from bed 1 month back, and following that he lost his ability to stand independently and decreased mobility of the lower limbs. No change in bowel and bladder habits, but the higher functions were normal. So we did tests and most of the tests were negative, but we did MAN2 test or TST with 5TU. Now we have changed our TST to 2TU, but in 2018 we used to do with 5TU because it was not available freely. Gastric aspirate for CBNet was positive, and chest X-ray, no consolidation or lymphadenopathy. As you can see, that the chest X-ray was not really that bad. But for the spine, because of the injury and the inability to move the lower limbs, we did a spine MRI, and spine MRI showed this lesion. But the spine MRI, while doing the spine MRI, you also have seen that there is a huge consolidation in the left chest, which was not visible on the chest X-ray. So our diagnosis was disseminated tuberculosis because CBNet was positive, MAN2 was positive, chest X-ray was positive, involving the lung, liver, and spine. Spinal involvement may be exaggerated due to the history of fall, no CNS involvement, and because of the patient had a hemoglobin which was low, we did an HPLC. Now our practice is to do an HPLC in all children. In all children, unless and until both the parents are negative, we do HPLC in all children. If you want to eliminate thalassemia from the country, everyone should know their thalassemia status, because many a times the parents, they don't do their HPLC before the marriage or before the birth of the baby. So this child is a disseminated tuberculosis involving lungs, liver, and spine, and no CNS involvement associated with beta thalassemia. The next case is, this is the last case, 1 year, 3 month old girl, generalized swelling of the body, decreased urine output for 7 days, poor feeding, cough and cold, and history of gastroenteritis 1 month back. The chest X-ray showed patchy consolidation and pleural effusion. Echocardiography showed normal heart and bilateral pleural effusion. Initial echocardiography had a course of antibiotics and no improvement. The child on admission at ICH was very irritable, periorbital puffiness, pedal edema, and abdomen was soft, but the liver was 3 centimeter palpable below the scapular line. So we did the repeat chest X-ray. The repeat chest X-ray showed clearance of this shadow with antibiotics only, but there was bilateral parenchymal involvement and there was little bit of cardiomegaly. With this cardiomegaly, we also did a CT scan of the chest, which showed patchy consolidations in both the lungs. But the CT scan also showed that there is pericardial thickening with loculated pericardial effusion and dilated inferior vena cava with congestive hepatomegaly. We did a repeat echocardiography, and repeat echocardiography showed a loculated SOL originating from the myocardium of the left ventricle and extending into the left ventricular outflow tract with myocardial thickening of left ventricular wall and septum. And there was mild pericardial effusion. So what we found that there were bilateral chest shadows, lung shadows. There were echocardiographic evidence of a mass. There was echocardiography in the left ventricular outflow tract, and there was pericardial involvement. So we did an MRI of the heart, and that showed that the mass is there. That was the cardiac MRI that we did. MRI repeated with contrast tissue characterization, and that suggestion was that it can be COX or it can be lymphoma. We did a cardiac MRI, and that showed that again the similar findings is COX and lymphoma. So our diagnosis was that most probably this is a tuberculosis causing bilateral lungs involvement, because there was no other features of lymphoma, and though the Mantoux test was negative, induced sputum was negative, we planned to start anti-tubercular drugs, which we did, because the biopsy from the lesion for tissue diagnosis was almost impossible. No one agreed to do the cardiac biopsy in this case. And there are reports that asymptomatic multiple intracardiac tuberculosis in a child from Maulana Azad Medical College by Dr. Dubey and his team. And this child on follow-up with anti-tubercular drugs improves. So myocardial tuberculosis is very, very uncommon. There are only very few reports in India. And so this is one. And we got the help of MRI in this case. One of the reasons I'm presenting these two cases is that we wanted to stress the importance of MRI. We have a fixed idea is that the chest CT is the best. Now, CT is very good for interstitial lung disease, but in most of the other cases, it may not be the best option. You can do the same result, get the same result with the MRI. Now, detection of pulmonary lung parenchyma lymph nodes can be done with MRI. See, the MRI will show you the lymph nodes, including the caseation, without the contrast. But if you want to see the lymph nodes in a CT scan and the caseation, you will have to give the contrast. So first you will have to do a plain CT scan, and then you will have to give the contrast, and then again do the CT scan. So the total radiation that you give, the total cost of the CT with contrast is almost more than the MRI that we do now in our hospital with 3 Tesla Lumia. Because the advantage of this MRI that we have is the time is reduced. We all used to say that the CT takes less time, which is easier for children. But now in our hospital, we do the MRI with the half of the time that is necessary for the other older generation MRI. Clearer definitions of structures involved, and changes in the soft tissue can be much better delineated with MRI rather than the CT scan. Alveolar pathology, cardiac pathology, respiratory can be seen better in MRI. And the newer MRI techniques such as parallel imaging can overcome the problems of motion artifacts, which people used to say that you will have to do. Now these are not the problems. Motion artifacts and susceptibility artifacts are not the problem now. And there is no radiation, as you know, and it is useful in situation where you will have to follow up. You cannot go on doing the CT scan, but the follow-up MRI may be a good option. And as I said, contrast is usually not needed, and cost of CT with contrast is the same as MRI. So in our hospital now, we don't diagnose appendicitis with CT scan. MRI gives the same success rate as that of CT scan. And this has been included in the recent up-to-date also, that either you do the CT scan or you do the MRI. So both can be done. And that is without radiation, especially in female children. We don't like to do the MRI of the abdomen because of the radiation to the ovaries. Thank you. Somnath?
Yes, sir.
কিছু
না, কোনো চ্যাটে কোনো কোয়েশ্চেন আনসার নেই। আপনি মিস্টার ডক্টর যাদবকে বলে দিন একবার ওনার বলার জন্য, পরেরগুলো যে ওনারা স্পন্সর করছেন সেই কথাটা একবার।
ডক্টর অশ্বিন যাদব, Dr. Ashwin Jadhav?
Yes, sir.
Yeah.
Yeah.
You can now take the stage.
Yeah. I have already shared my screen. My voice is audible, sir?
Yes, very much.
Yeah. Okay. Thank you, sir. Good evening, all of you. This is Dr. Ashwin from Zydus. I thank Dr. Ghosh and ICH for giving me the opportunity to present NEBAIR in front of you. Without wasting any time, I'll directly start my presentation. NEBAIR is a mesh nebulizer, first time in India. As all of us are talking about, there are different challenges with the use of inhalation therapy in children, especially because of the smaller airways, nasal breathing, and difficulty mastering the complex steps required for the effective and aerosol administration. The breathing patterns are also erratic, so they may not have the sufficient hand-to-breath coordination, and the use of PMDI without VHC may not be a good option. So apart from that, you need to choose the drug and the device very carefully with the availability, the cost, and acceptability of the family. So please do remember that less than 12 years of a nebulizer always remains an option for you. But of course, that depends on the lots of other factors that we have just seen. What do the guidelines recommend? That is the problem. The last guidelines, international guidelines, which were published on home nebulization was in 2001 by European Respiratory Society. So they recommend the inhaled therapy optimization protocol for the individuals who thought to be inappropriate for the what we can say nebulization therapy. So with the paucity of time, I'll just go through it. First, check the diagnosis and confirm the severity. Please ensure that the patient has already tried the appropriate therapy. Optimize the existing therapy by using increasing the dose. If the patient doesn't respond poorly to the measures, then you shift the patient to 2 weeks of home nebulization therapy. If the response to monotherapy is poor, definitely you can use nebulized salbutamol, ipratropium, and mixture of salbutamol, terbutaline. Now decide with this patient which of the therapeutic intervention is. So this is what we can say ERS recommended in 2001. But as of India is concerned, there are lots of nebulization devices which are available, but mostly they are limited to the jet nebulizers. The jet nebulizer is an open structure where we have compressed gas in the form of compressor, which will convert the liquid into the aerosols. The portability is restricted. There is lots of noise. The treatment time is longer. Mostly jet nebulizers are used only in emergencies where the doctor and the treating physician wanted to give the higher dose of a drug, and the residual volume is used. Most of the studies say that 2/3 of the drug is lost in exhalation. There is a continuous use, and of course there are newer technologies coming like ultrasonic and vibrating mesh. Ultrasonic, they use ultrasonic waves to convert what we can say liquid into the aerosols, but unfortunately they are not very good with the co-suspensions. They are very good with the liquid thing, but they are not very good. And second important is that chances of denaturation of the drug is possible with ultrasonic nebulizers. Now we are going to definitely talk about vibrating mesh nebulizer. Nebair is a variable frequency mesh nebulizer. So there are two working modes. This is the only nebulizer in the market which has the two working mode, that is variable frequency mode, where you can actually increase the nebulization or decrease the nebulization rate as per your choice, as per the discretion of the physician to improve the absorption. Second important thing, we are using artificial intelligence in our nebulization the way that it automatically detects the patient's breathing pattern in the first 3 seconds, try to establish the breathing curve, and deliver the pulse delivery of the aerosol when there is inhalation. So the nebulization rate changes circularly according to the human respiration, which brings a very comfortable nebulization experience to the patient. Not only that, it will provide higher delivery of the drug in the lungs. So I think this is one of the important points. Second important principle of working, as you can see, an annular piezoelectric element is mounted on the mesh, which is in contact with the drug. Now the holes in the mesh are conical in the shape, where the largest cross section is in the contact with the liquid. So this vibrating mesh will deform on the liquid side and convert this liquid into aerosol, which can be inhaled by the patient. Now, if you talk about the technical features, the nebulization rate is 0.15 to 0.9 ml per minute, which is absolutely fine if you compare it with the jet and other nebulizers. MMAD, mass median aerodynamic diameter, that you usually see, it should be less than 5 microns. If you see with our mesh nebulizer, it is 2.5 microns, and more than 50% of aerosols which are generated, they are less than 5 microns, that is 1 to 5 microns in size. That is the equivalent particle size distribution of our nebulizer is 1 to 5. The cup volume is 10 ml and the noise is less than 50 decibel. Not only that, if you see this picture, we have a spatial alloy mesh which is corrosion and high temperature resistant. We have a chip which will help in our different two modes that we are using on nebulizers. And third, we have a titanium lithium battery which is rechargeable. So if I wanted to summarize, there are two titanium one core raw material technology which is not easy to break, 5 years for warranty with lithium battery, intelligent operation system, microwave nebulization technology with the rate changes from minimum to maximum automatically without any interference, or you can actually manually change it as per your convenience. So we have microwave and variable frequency nebulization technology. Not only that, one of the major problems faced by the mesh nebulizers when they've introduced in the market is that they get blocked, they get clogged, so patient doesn't get any kind of medicine. Now our device, if you switch on the device, it will enter into the self-cleaning mode when turned on and crank up the power to eject the residual drug with a greater impact for within first 5 seconds, which will decrease the chances of drug blockage. That doesn't mean you don't need to wash the nebulizer once the nebulization goes. Of course, you have to wash, which we will come to that. Not only that, we have a magnetic medication cup and a design patent. Now, everybody knows that the mesh nebulizer technology is not only for the obstructive airway diseases, that is inhaled corticosteroids and bronchodilator. It is going beyond that. There are lots of drugs like tobramycin, pulmozyme, pentamidine, which are also approved by the US FDA with a particular type of nebulizer. But right now, we are focusing only on inhaled corticosteroids and bronchodilator for Nebair. Now, if you wanted to see the assembly, you can connect the medication cup, align the guide rails on both the sides and push them into place. Either you can use the mask, the mouthpiece and start inhaling. How to use, this is what we can say. First step, open the medication cup lid. Second step, add the proper liquid drug. Please do not exceed the maximum scale indication. Close the medication lid, connect to the mask or the mouthpiece and start nebulizing. Now this nebulization machine is so small you can carry anywhere. So portability is very, very good. If you long press this button, you can interchange between the nebulization, either a variable frequency mode or a microwave mode. This is the sign to increase the atomization rate and this is the sign to decrease the atomization rate. Now, one of the important points, if the battery is fully charged, you don't need to carry the charger. But if the socket is available and the battery is not charged, definitely you have to recharge the battery. This is the only mesh nebulizer in the market which offers such kind of convenience to the patients. Now, one of the most important, how to clean it. First, open the what we can say lid, clean the internal medication cup, clean the external of the spray connected interface, and then clean the internal spraying of connected. One of the most important problem with the jet nebulizers, the lots of tubings and compressor and big thing. So actually you cannot disinfect the tubings, which can be definitely overcome by the mesh nebulizer like Nebair. Not only that, our mesh nebulizer can be also be used for the patients who are ventilated. Either they are using NIV or they are intubated. Definitely they do not disturb the breath circuit, and you can still nebulize the patients which are ventilated. So if I want to summarize, Nebair is a mesh nebulizer which has a less blockage with self-cleansing technology. It will enter into automatic cleaning mode when turned on. It has a very less residual liquid as compared to jet nebulizer, which almost 2/3 of the drug is lost by exhalation in the residual liquid. Not only that, sometimes you have to add 3-4 ml of the normal saline to the drug so that the patient is able to inhale and some amount of drug will deposit in the lung. It generates very low noise. It is portable, easy to carry. The proportion of particles which are less than 5 micron, which is very, very important for any aerosol to enter inside the lung, is more than 50%. We have a patented variable frequency nebulization technology where you can actually increase the nebulization rate if you want to. There is a durable titanium mesh material which doesn't easily break. Not only that, the charging capacity. Once you charge it, you can actually use it like your mobile with a 5-year service warranty, and we have an intelligent operation system. I think that's it from my side. Thank you for your patient listening. Over to you, sir, Dr. Ghosh. I have stopped sharing. Hello, Dr. Somnath.
It's all right, sir. You
Yeah,
can
yeah,
quit.
yeah.
Okay.
Yeah, thank you.
Anirban, can you hear me?
I can,
Anirban,
Dada. I can hear you.
can you hear? Yeah.
Yes, I can.
Yeah, Doctor. Our next speaker is Dr. Anirban Maitra. He's the pride of India, pride of West Bengal. He is the consultant respiratory specialist in Manchester Children's Hospital. He has a huge work on respiratory diseases and especially on cystic fibrosis. So we'd like to hear from Anirban Maitra now. Anirban, can you share your screen?
Yes, thank you, Dada. I'm in a very informal dress. Thank you for this kind introduction. And I've always would have wanted to work with you guys. I just wanted to go into and share my screen, which is going to be, can you all see it? Can you see?
Yeah, yeah.
Okay, thank you so much. Thank you, Apurba, again, and ICH and all the sponsors to have invited me. And any opportunity for me to come back and touch my home is always very special. So I know we're just going to be talking some basics over here, and I just thought I'll share some of the sort of contemporary views and stuff like that, so that I'm not going to talk any hi-fi over here because I think that's not something which is necessary. So I would start by saying that my preliminary introduction would be there, some case studies, followed by a little bit about cough and wheeze, so as to be finishing within time. Now, this is the hospital where I work. This is the biggest children's hospital in UK and the second biggest in Europe. And I do look after the biggest cystic fibrosis unit in the country, which is 350. But then if you compare that number to Professor Cabra, who many of you might know All India institutes, this is just minuscule because Professor Karbra looks after almost 900 patients, and that's a mammoth project. We are a very small number over there. This hospital is one of 5 hospitals, now part of 12 hospital group. And I don't know whether you can see this over here. So this is where the hospital sits. So in a big complex. So this is the Children's Hospital, followed by the Maternity Hospital, also known as St. Mary's Hospital. Then there's the Eye Hospital. And we have over here the original old hospital called Manchester Royal Infirmary. So many people still know us by the name Manchester Royal Infirmary, although it is 4 hospitals in one set. And there is the dental hospital, 2 other major hospitals elsewhere. I also go to another small private hospital, which is called BMI Alexandra Hospital. I have not put a slide over there that I haven't received any I don't have any financial disclosures with this presentation. So back to the topic that we wanted to understand cough and wheeze in children. And I just wanted to highlight my take-home messages from what I've understood all along. So let's take the first case. Her name is Zainab W. She's 14 years of age. She was a resident in Preston and moved to Manchester recently. So this is just a quick map. I don't know how clear it is. So Preston is a little place which is slightly far away from Manchester, maybe around 40 kilometers away. So this road is quite interesting. This is Liverpool, this is Leeds, and this is where Professor Ghosh worked at one point, which is why I've highlighted that. So Zainab had a cough for past 6 years, intermittent and wet. She has been going to her GP. The GP might have thought, I don't know how many of you know the system over here, that people cannot come and see a pediatrician unless they have been seen by a GP. So general practitioners act as gatekeepers to the NHS. So they have to actually understand the problems. Sometimes they understand it quite well, which I'll show a couple of cases. Some of them are very good, some of them are not so good. So this child had a cough for 6 years, intermittent and wet sounding cough. And she might have also been heard to have wheezing sounds. She had responded to oral antibiotics. GP has given Clenil, and Clenil is beclomethasone and montelukast. And there has been not much improvement on those medicines, no significant previous medical history, not on any other regular medications. So unfortunately, her father passed away and the family moved to Manchester. And whilst they came to Manchester, they had a new GP. She had a new cough. GP gave antibiotics, cough improved, but did not go away completely. So GP requested chest X-ray, and the chest X-ray changes worried the GP, and he made the referral to us, to Royal Manchester Children's Hospital. So when we had to look at the X-ray, of course, as you all can see, and Professor Ghosh has gone through all the complicated X-rays in the past, this is a clear case of good going consolidation over there in the right middle lobe, but can't say what was the status of right lower lobe. So additional history, when I saw the patient in the clinic, I found that the parents were first cousins, and I gave a 2-week course of antibiotic. And then after that, I took an X-ray, and the repeat chest X-ray was identical. In fact, this X-ray that you are seeing is a repeat chest X-ray. So I admitted her for IV antibiotics and intense chest physiotherapy. So in UK, we have a subspecialist of physiotherapists who does only chest physiotherapy. And then they have super specialization. Some of them would be doing cystic fibrosis. Some of them would be doing dysfunctional breathing. Some of them would be doing bronchiectasis. But they do not do any other form of musculoskeletal physiotherapy. So in that way, they have much more concentrated expertise, but not a very wider expertise, which our physiotherapist colleagues in India have got. So we noted that there's no allergies at that point. So by which we mean that we are no longer doing the skin prick test because it could be quite inaccurate, although our dermatology colleagues might still be doing it, and also allergy colleagues. Mainly we do total serum IgE, which may not be a good marker in India given the high incidence of parasitic problems, as well as ABPA related things. But in UK, it's a fairly sensitive marker of allergy. And we also look into RAS tests for aeroallergens and various different things. So when I say no allergy, I meant that those panels were all negative. We looked into immunoglobulins, by which we mean immunoglobulin G, A, and M, and lymphocyte subsets, which is, I know when I was there in Kolkata, it was available in certain labs. So I know we have been doing that. We do sweat tests over here, which is a very specialist method and not the method that we have been using and preponderantly in India. In fact, some of the places in India, like in Vellore, they use the proper one called macroduct technology, which is very expensive, but they are doing it part of a pilot project. And we also look into alpha-1 antitrypsin status. And we did an HRCT after the intravenous antibiotics because we felt there might be something more sinister. That's the CT scan, which clearly shows that that dense area, which was apparent as a consolidation, is not a consolidation. In fact, it is more like a saccular bronchiectasis, very localized, involving that area, some involvement in the left lung too. So we then went for some cilial brushings. So this is a special test we would normally do. There's a little bit of a wait for it, unfortunately. So we take some samples of respiratory epithelial cells from the nose and send it to Leicester in a viable transport medium. So it's a live medium, and it's usually sent by motorbike couriers. And so it's like almost like a VVIP treatment. So you do the test, the courier is waiting, you give it to them, and that goes off. The journey, which is almost 80 miles from Manchester, is actually covered maybe within an hour or so, and the live specimen is delivered to Leicester. Leicester is our national center looking into this. Now at Leicester, what they do is that they try to grow an artificial respiratory epithelium in culture medium, but they also do some basic tests. So what they do is they do video motility tests. And to those who don't know about video motility tests, this is a high-speed video microscopy. So what they do is this, under a very high-speed microscope. Normally the microscope, the video speed of our camcorders is somewhere between 25 to 50 frames per second. But this one uses around 2,500 frames per second. So it's a very high speed, and it can see things moving, the cilia's beating, and the patterns of their beating is noted. They're usually done in air cushion, because even a slight vibration or a little bit of a draft of air might make things really worse. So this is a special test. Sometimes if you have an acute infection, you might not get a right result. Therefore, you might have to repeat it, and might have to repeat it from the cells that you've grown artificially in the culture medium. So on this child, we had a confirmed diagnosis of PCD, or primary ciliary dyskinesia. And the child was put onto regular 3-monthly intravenous antibiotics and intense chest physiotherapy on a daily basis, as well as intense chest physiotherapy when they come in. And I know Arabica is now available in India. 7% saline, as far as I know, is not. But I know the 3% saline is available, and somewhere in Vellore, they are trying to get some 7% saline nebs. So she had remained stable. She hasn't worsened, and she appeared for GCSE this year. So the moral of the story is that wet cough requires further evaluation. Am I still being heard? Is it? Am I still okay talking? Hello, Apurba?
It's okay. It's okay.
Oh, okay,
it's okay.
sorry. Okay, so the next case is Clara. Her father is a big shot advisor to the government. She lives in one posh part of Cheshire. She's 15 years of age. She complained of mild shortness of breath over a few days, but no cough. She has been very active. It's a health freak family. They all go for biking holidays, and they go for biking somewhere between Thailand to Cambodia, and they spend much more than flying. So these kind of family. She had no major problems beforehand, but then she was complaining of a bit of tiredness, which often is the case at that age, and especially with increased amount of studies going on and academic pressure. But one thing is this, that she was unable to wear any nail extensions. Now, to me, before my daughter was of that age, you know, I was unable to understand what a nail extension was. I'm sure many of you know this, but for those like me who did not know it, you know, these are nail extensions. So she said that she cannot wear a nail extension. And a very clever GP then noted clubbing because of the extensive curvature of the clubbing, so nail extension could not be put in. So he requested a chest x-ray. There were some changes. He gave a course of antibiotics. He repeated the x-ray. There was no change. He made a referral to another hospital called Wythenshawe Hospital, which is again within Manchester, now part of Manchester University Hospitals like us. The x-ray was repeated afterwards, no changes noted, and therefore was referred to our care at Children's. So when I had to look at her for the first time, she appeared very well nourished, but she did have appear to have clubbing and fine crackles on auscultation. She had a restricted spirometry. She had very low levels of baseline saturations, which dropped with effort. She was flying off to Germany on a school trip a week later. Unfortunately, I organized a flight assessment test on an urgent basis, and that came back as negative. And so she had to go by car instead, because she would have become hypoxic on a flight. So that was the outcome of that test. So she had a normal sweat test to look into cystic fibrosis, normal immunology, rheumatological markers, allergy markers, PCD testing, echo and ECG was normal, and a CT scan was performed, which shows, as you can see, some geographical picture. So some areas which were darker, some areas which are much more brighter. Now, this is the dilemma for the radiologists here. Often they are not able to say which is the normal lung, and we have struggled too. Sometimes it is made easy by inspiratory and expiratory cuts, but then not always it is possible to say, is that the black part, which is the normal one, or it is the white part, which is being normal lung being compressed by the abnormal black part. So of course we went for a lung biopsy, and it was inconclusive. They could not come up to any conclusive picture. This is one of the things I want to highlight, that lung biopsies are important, but they may not be able to put into any particular group of known interstitial lung diseases. Anyway, interstitial lung disease was suspected. The surfactant protein mutations all came back as negative. We looked for reflux. There was no reflux on pH and impedance study. So we considered this as idiopathic. A bronchoscopy was also normal. I didn't put it over there. So we went for 12 pulses of pulsed methyl prednisolone, and we gave hydroxychloroquine. And towards the end, this was the outcome. During this period, the family and I felt that there is a need for sharing this child's care with some other institution. And as you know, Andy Bush is a good friend of ours. So he works in a hospital in London, Royal Brompton Hospital. So he and me, we jointly sort of managed her until she came to that age when we had to say goodbye, because she was 17 and a half and 18. So we transferred her care to our adult colleagues. So, so the lung physiologies, lung functions, oxygenation, everything improved. I, in fact, saw her a few months back. She was raising money for charity, and she appeared very well, but not as a patient, but more like a charity volunteer. So I wanted to highlight over here that shortness of breath could be very insidious and may not be associated with any cough and wheeze, which is what happened to this girl, that she didn't have any cough or wheeze, but she did complain of an incidental shortness of breath and tiredness, and a very clever GP found out there might be something wrong with her. Third case is about Grace. She's 13 years of age. She had a diagnosis of asthma in childhood. She had frequent exacerbations. She had frequent visits to A&E, and parents were frequently called into school. She goes to a private school, and they have often called the ambulance because of her acute exacerbations. GP has been maximizing her therapy. Inhaler technique was considered as good. Compliance was good. Parents were really distressed. Her education was being hampered, and she was referred to us from that perspective. So when I had to look, she had a good inhalation technique and compliance. IG was elevated at 2,500. RAST was strongly positive to Hustus mite. Treatment was optimized in a sense that we added up antihistaminics, and we added nasal sprays like Avamis, and we tested for other things. She had a normal spirometry despite this, an X-ray, and HRCT, as you can see from this. So although we thought she might have asthma and allergic rhinitis and being atopic, but we were unable to explain why would she be so poorly so as to need the ambulance to come to the hospital. So mom had been taking some videos from home, and I saw, and she'd sent me some videos, and I found them quite interesting. So she said that she was continuously coughing, and that cough completely disappears when she sleeps. So that was one clue. And on one of those times, when she was unwell, I asked her to come into the hospital. So when she was over there, she was involuntarily having vocal tics. I luckily got hold of an ENT consultant who was just walking next door, and I just said, could you do a nasal endoscopy just now? She did it, and we could clearly see vocal cord dysfunction. This is a very difficult sort of situation. Psychogenic cough, habit cough, vocal cord dysfunction are things which takes much more of our time and convincing, because we would rather have a medical diagnosis where we can talk and say, look, this is your problem, this is what we can do, because much of this is difficult for the family and for the child to comprehend. So we got our psychologist and respiratory physiologist and physiotherapist involved, and they taught various breathing exercises and went into deep root. And I've now seen a number of such cases, and I have seen such cases when I was in Kolkata too. In fact, one of them was referred to me from Bellevue Hospital, who was ventilated for almost 8 days. So ventilated for 8 days for respiratory problem. She then got transferred to what was then Amri Women's and Children's Hospital. I was over there, and one day I could see everybody running around and rushing around because she's pulled the the emergency buzzer. We were all over there to see, and then she stopped saying and said to me, this is so classical that unless you see that poor child was ventilated for 8 days for no respiratory problems. And it all transpired that she has a boyfriend who's not accepted within the family and all those things. I think there's a deep-rooted psychological rationale behind such problems, and that needs to be explored, particularly as India becomes affluent, as these problems become much more common, like the Western world. There is a need for shifting from what is the medical explanation for a cough and wheeze to something that could be psychological. So now the events are much more controlled, and she has got a much better acceptance. The family has accepted that these are events which should not be medically managed in that way that has been in the past. I think that was a good learning lesson for all of us. So just to take home point over here, that if you have an asthmatic whose symptoms are not getting better, that child might have dysfunctional breathing. Finally, the last case is Rory, 2 years of age, normal pregnancy and normal newborn period, frequent wheezing episodes since 4 months of age, multiple admissions, associated with a wet chesty cough. Mom reports that colds can go down the chest fast, and it persists. And the GP has trialed inhaled corticosteroids and LTRAs. There has been no response. The chest X-ray has been reported as normal. Antibiotics has not made a difference either. And then with that background was referred to our care. So when I had to look, he had a fruity cough on crying. By the word fruity cough, we mean a wet wet cough, as if he has got secretions rattling around his chest, which he was unable to bring it up. Did have minor wheezing too, but comfortable breathing, normal saturations. Chest X-ray showed a minor increase in bronchovascular markings. The tests, as you can see, were all negative. We did a cough swab. Now, those of you who do not do cough swab, the difference between a cough swab and throat swab is this: that cough swab is a throat swab taken in a very special way, where the tip of the swab hangs in the oropharyngeal space without contaminating the tonsillar pillars and the pharyngeal walls, and the child is asked to cough on it. We teach our children with cystic fibrosis and those with bronchiectasis to do it on a regular basis. In fact, by default, initially their parents do it, and then followed by they themselves can do it. We ask them to do it almost on a fortnightly basis. So on an average child with cystic fibrosis, we should be getting almost 24 odd samples, some sense more, some sense less. So cough swab on this occasion grew Haemophilus. We gave 2 weeks of coamoxiclav, and the cough improved, but the wheeze continued. I then optimized the dose of Clenil, checked the inhaler and all those things, but after 3 months, there was no response. So I organized a flexible bronchoscopy, and I did some dynamic assessments with bronchoalveolar lavage. Now, this is a picture which is not from that patient, it's from somebody else. I just wanted to highlight this. I don't know whether it's clear or not. So this is a normal trachea, as you can clearly see. This is a D-shaped picture, and with the posterior little mild bulge, this is normal. So normally when you cough, this might bulge up to this. So this is a picture of a child with true tracheomalacia, where there's a lot of narrowing. Arbitrarily, it is more than 50%, 50 to 75% is mild, 75% to 90% is called moderate, and more than 90% is severe. And my lecture is not about tracheobronchomalacia. I just wanted to highlight that these kids present with wheezing. So if you have a child in front of you who is wheezing, you do need to think about it. And then I need to highlight one thing, and I've highlighted this to my distinguished colleague, Pallab, on multiple occasions, that there are methodological differences between bronchoscopies. I do bronchoscopy in a completely anesthetized patient, although at a lighter plane of anesthetics, which is very, very different from what I have seen being done in the Indian continent. There is another way of doing bronchoscopy, which is the DLTB, or the direct laryngotracheal bronchoscopy. If you do it in that way, you splint open the airway, and areas of airway malacia may not be apparent. So if you want to do the, you want to sort of look for bronchomalacia, tracheomalacia, then you should be looking for primarily through a flexible bronchoscopy. And we also grew Haemophilus from the valve, and then we made a diagnosis of airway malacia and persistent bacterial bronchitis. In fact, if you look into them, they often coexist, but nobody knows why. I have got some theories, but that's again beyond time for discussion today. The mainstay has been physiotherapy for this, because often they get better, the cartilage matures and these things get better, and the secretions come out. Often nothing more is needed apart from some physiotherapy, but in severe cases, you might need to do a tracheostomy over here. You might need to put a stent in very rare cases. Some of these patients can have been benefited with a special operation called aortopexy, which pulls the aorta up, with which the anterior aspect of this gets pulled up, or sometimes this posterior bit can be stitched to the spinal ligaments. So this is called posterior tracheopexy. So anyway, that's again not something which I wanted to talk about. Just wanted to say that in tracheomalacia, there could be potential narrowing and retention of mucus, which can lead to bacterial stasis, and then can lead to major problems with infection and the vicious cycle of infection. So airway malacia, bacterial bronchitis is common and fails to respond to standard treatment. So just be aware of this. So understanding cough. Before this document came out, and I was lucky enough to work with Mark Everard, who was my educational supervisor, and Rob Primack, who was my clinical supervisor. And there wasn't much available. In fact, people would have done things on their own different ways. As you know very well, that that practice has now been replaced by evidence-based care, and this was one of the first steps. But this is a bit outdated now, because this is 2008 guidelines, and Unfortunately, there's no new guidelines which has come up from the BTS, the British Thoracic Society, but some minor changes I will highlight. Just wanted to highlight some interesting facts about cough, that normally children do cough. So if you ask somebody and in your private practice and you ask somebody, "Oki kashe," and the answer is "Dr. Wu kasche." But that's because hypersensitive parents are always listening to this cough. And normally kids could cough somewhere between 11 times to 30 times per day. You know, that has been looked into in research studies using special equipment which can record coughs, audio equipment which can record cough. And the majority of them who have a cough have got a viral upper airway infection, and that happens at least in the UK and in the European continent 7 to 10 times a year, almost at the frequency of once every month, but then more in some places like in Manchester, which is wet and windy, as compared to somewhere in southeast of England, like Dover. And then also clustered. Summer months you get less, winter months you get more. Interesting that 50% of them would get better by 10 days, and but 10% might still have a cough lingering going on for 4 weeks. So just because somebody has coughed and has not been happy with a previous colleague of yours is not an indication to start and think about something more serious, because you need to think that a normal cough takes much longer to get better too. Because it's a simple upper airway infection which is triggered by a virus, usually no investigations are needed. And an absence of fever, tachypnea, and chest signs are the most important markers. So if you think about inhaled foreign body, which you can think of any cough below the age of 5 years, an urgent bronchoscopy, and that time a rigid bronchoscopy is important, except if you are sending the patient to Varinder Singh, who is a consultant at Lady Harjan Hospital, who is one of those very few doctors who can use flexible bronchoscopy to retrieve foreign bodies. I have been helping my ENT colleagues with Domia baskets and stuff like that, but I do not claim that I do remove foreign bodies. So it's usually the ENT team who would do it. Chest X-ray needs to be considered if you are suspicious of lower respiratory tract signs. Over-the-counter medications like cough syrups and stuff like that, you know, which abound the market, are of no use. They don't work. And whatever you use, you know, I can tell you with a lot of certainty that almost majority of them do not work. In fact, the thing which works is the age-old thing of pachun and honey. Honey can be given after the age of 1 year, and pachun, homemade stuff like that, tejpata, alach, and all those things, you know, they do work because they all act as demulcents, and they all sort of help, you know. In fact, the ones with the C's in it, like the something with C, all those tonics, all those cough mixtures, they could be quite dangerous because you're suppressing the cough, which is a normal natural reflex to clean the chest, and you are also making sure that the mucus is becoming much thicker. That is a perfect recipe to contribute to a pneumonia. Antibiotics, as I said, is predominantly not needed. And if you think pertussis, you need to use it early. Antihistaminics, steroids are not helpful if you don't suspect that they're happening because of a allergy. Now, this is a slide again from that story, that particular document, which shows that most coughs get better, but you can actually have a second onset cough. For the family and the parent, they report this cough and this cough. So actually for them, it seems like that the cough hasn't got better. So I specifically asked, has there been a day or two where the cough has gone away? And many of them say, yes, that went away for 2 or 3 days. And then this is the new cough coming through. But this is now going on for 3-4 weeks. So this is not going on for 3-4 weeks. Instead, this is going on for maybe a few days. And again, as I said, most coughs tend to get better. But we need to be worried about this bold line cough, which tends to worsen if, this is the cough that we need to investigate. I think in the interest of time, and I might not actually continue to go through this, cough, according to the British Thoracic Society, go through sort of 3 major things. One cough is acute cough, which is usually because of acute inhaled foreign body allergic rhinitis. This is a cough which is defined with less than 3 weeks of age. Pneumonias, croup, tracheitis, and all these things falls into this, or also could be a presentation of the chronic disease. Then there is a group called 3 to 8 week. This is a prolonged acute cough. Now, this is where the European Society and the American Thoracic Society is deviating, because they now think that any cough more than 4 weeks is to be considered as a chronic cough. So, which is a slight deviation between the definitions. So I just wanted to highlight that if there's any specific pointers in history and examination, you need to go for a chest x-ray. You need to then look into the various causes, which I wouldn't go through in more details. But if you have a child who has been coughing and you are convinced that the cough is a continuous cough more than 8 weeks of age, beware, and you need to do everything. So you probably have to sort of think about all these conditions, which includes over here psychogenic cough and other things like cystic fibrosis, which happens. During my time, whilst I worked at Institute of Child Health, we had 25 patients with cystic fibrosis. And I think cystic fibrosis is there, PCD is there, it's just that we've not been diagnosing enough. I'm just going to skip this and just wanted to highlight the red flag symptoms.
Anirban,
yes?
You need to, because we are running out of time, you know.
Okay, I'll just go through quickly, maybe another 5 minutes. Okay, so I'm just going to be sort of saying that beware of this condition called bacterial bronchitis and non-pulmonary causes of cough and psychogenic cough. I just wanted to highlight one thing, that what is bacterial bronchitis? It is the presence of chronic wet cough without with the absence of any symptoms or sign, and a cough that gets better with a 2-week course of antibiotic, usually coamoxiclav. And if you isolate things like Moraxella, Haemophilus, Streptococcus pneumoniae, and Staph from any of the lower respiratory tract microbiological specimens. I would want to sort of also not talk about primary ciliary dyskinesia, which is estimated to be prevalent between 1 in 10,000 and leads to impaired mucociliary clearance. And leads to other problems like situs and conductive hearing loss, bronchiectasis. Just wanted to say many tests could be done, including nasal nitric oxide. And I don't think these tests could be done, but I must say that at the All India Institutes, Professor Cabra has brought in this high-speed video microscopy. Nasal nitric oxide is normally low, and this is high-speed video microscopy I was talking about earlier on. This is a highly specialist test, probably now available at All India Institutes. And we also can avail transmission electron microscopy, which I think can be done in Kolkata too, and PCD genetic testing and immunofluorescence studies. And again, guidelines available there. I don't want to touch all these things. I just want to skip. And just 1 or 2 lines about wheezing. We came to know about wheezing more from 1995. Before that, everything got clumped together. Study from Martinez and Tucson was the eye-opener. And then we found out the different categories of wheezing, those who tend to get better, those who don't tend to get better, and the ones who tend not to get better are the asthmatics. But at a standpoint, at a given point, you never know which one what you are actually doing. This was complicated by my own boss, who unfortunately passed away, John Henderson, and the ALSPAC studies show that there are many subtypes, and each of them can follow the asthma type, and they can actually get better in some stages. So we should not be calling asthmatics at very early stages. And there are a number of reasons one can wheeze. I don't want to go through them either. These are the common causes for that. And there's a good ERS task force which looks into various different preschool wheezing things. And for those who want to sort of know about it, you know what to go for that. And that's what I should finish.
Thank you. Thank you, Anirban. Actually, we are running short of time, so I had to stop. I'm sorry for that.
Okay.
Actually, after that, there will be 2 lectures, one by Pallab and the other by Priti Khemka. So
no worries. I'll come out here. Thank you so much. Thank you.
Yeah, thank you. Thank you. Pallab, can you start quickly?
Yes. Thank you, Apurba, for your kind invitation, and it is always fantastic listening to you, and then again after you, Anirban was such a brilliant talk with all these varieties of cases that he showed from his vast experience, and it was wonderful listening to Anirban after a long time. And thank you, Anirban, And thank you, Apurba, for this lovely opportunity. Okay, so what I'm going to talk now is a few respiratory sounds, and I'll start off straight away with the first case where this was a you can see when this child is crying, then there's some amount of inspiratory sound that is being produced, but you can't hear the cry. And this child was having difficulty in feeding, and this was the reason the vocal cords were fused. So when we did the bronchoscopy, we could separate this. So we had to do a bronchoscopy at around 10 hours of age, and just after the bronchoscopy was done, here you can hear the loud and clear expiration that we want to sound. And this child was actually referred to us by because of respiratory distress and difficulty in feeding. So when we look at the categories of respiratory sounds that are available, so there are various types of sounds that are there. The basic sounds, which are the normal lung sounds and the normal tracheal sounds. And then there are the adventitious sounds, the V's that we all heard just now from Anirban, the rhoncus and the crackle. We won't go into much details, but what we need to know is the various acoustics that lead to these changes, because these are the things that come into picture nowadays with the advent of the newer types of auscultatory methods. So this is again a very common scenario. A 1 year, 8-month-old male, noisy breathing, very hyperactive, difficulty in feeding, difficulty in sleeping, aneurysm, and this is what we would like to do at present. But this child was having real problems. So this is one of the common things that most of us do, an X-ray to look at the size of the adenoids and the tonsils. But this is something which we don't need to do. So you don't need to actually do an X-ray or a CT scan of the nasopharyngeal space, and you don't need to look at, because the size of the tonsils and the adenoids are not important. So you need to manage these children. And what is actually a snore? Snore is basically a flutter of the tissues in the pharynx. So it is less of a musical quality, and it's present more during inspiration and expiration. So if you want to actually see a snore, so this is what Bob Wood used to say, that any sound that is produced in the airways is visible. So this is a visible, this is the snore that is happening. So you can see the flutter of the airways that is happening during a snore. So this is a technique that is called the DICE, the drug-induced sleep endoscopy, where you can see. So this is done once, and you gradually give incremental doses of midazolam, keep the bronchoscope just in the nasopharynx, and you see which sides are coming closer and how is the flutter, and that's how you can grade this according to the Colorado DICE grading scale. And this is done when your obstructive sleep apnea, you have done everything, you have done a adenodectomy, and you've been trying CPAP but it's not working. Then you want to go for the other surgeries if you want. Most of our children, they respond to adenotonsillectomy, because hypertrophied adenoids are the commonest reason for severe OSA. But what we need to understand is they will peak around 5 years when the lymphoid tissue, the growth is maximum. So first we should go for the medical treatment and then only surgical. This was another child, a 1-month-old female child, who came to us with respiratory distress since birth. So now this child is having respiratory distress since birth and noisy breathing since birth with recurrent respiratory infections. This child was managed at a... So you can see this child is breathing, is very labored breathing, and this child was having a stridor. So stridor is basically a musical sound. It's caused by the oscillation of a critically narrowed extrathoracic airways. So because of that, there is a inspiratory sound. And what we usually think about these patients is they are having a laryngomalacia. Now, this is what a laryngomalacia is. There are various classifications, various grades of laryngomalacia, why it is caused, how it is caused. But basically what happens is it's a long infantile epiglottis and omega-shaped epiglottis, which closes on itself. It can fall back onto the arytenoids can fall forwards, and the inlet sort of gets compressed. So this is how inlet is getting compressed, and this child is having problems. But whenever one sees a laryngomalacia, one should go in and do a bronchoscopy, because it can be associated with tracheomalacia also, tracheomalacia and bronchomalacia. This is important that it rarely starts from birth. So yes, you can have, not that you cannot have, but it's extremely rare. So if you have a child who's having a severe respiratory distress, which has started since birth, with an stridor since birth, and not gaining weight, so it's not the usual garden variety of laryngomalacia where this child is not gaining weight, having recurrent respiratory symptoms, then it is the time to think of something else and do a laryngoscopy and to evaluate what is the reason for this, because this laryngeal malacia usually has an onset after a month, so it's usually 4 to 6 weeks. And when we did the bronchoscopy, what we found is there was a big cyst over here, and this cyst was pressing on the epiglottis, and that was what was causing the problems. So that is the reason why, if you have something which is out of the ordinary, we need to look into the matter and see what was the reason for this problem. And this child was immediately after nearly gone. The breathing is so comfortable. So that is what happens with a laryngeal cyst. A supraglottic cyst usually is congenital. A subglottic cyst is usually prolonged intubation and all that can cause a subglottic cyst. Appears like a submucosal mass as a subglottic cyst, and there can be various problems like stridor, hoarseness, aphonia, and feeding difficulties. Another child, an 8-month-old, another acquired problem, recurrent respiratory failure, tetralogy of Fallow, BT shunt was done, had a stormy period, shock, and when this child was crying or when this child was breathing, a whistling sound could be heard. You can hear that whistling sound. There was a typical whistling sound that was being heard, and this was again what usually happens is people try to stuff in the largest bore of endotracheal tube that is possible, particularly when they want to go ahead with a prolonged surgery or a difficult surgery. They don't want the ET tube to get displaced in between the surgery, and this can cause problems. So it's better to have one size smaller. So you can see that the laryngeal web that has been formed, and that is the reason why this child is having these problems. If it is very soft, it can be broken with the bronchoscope itself. Otherwise, you need to do a cautery and a surgery in this child. So these are laryngeal webs. Congenital is very uncommon. You can have membranous laryngeal webs which are congenital, and acquired synechia is much more commoner. This was again a child who presented with stridor since birth, again was diagnosed as laryngomalacia, 3-month-old. So again, when you have a child who's having a stridor since birth, having difficulty in respiration since birth, recurrent respiratory infections requiring antibiotics, then you start thinking that may not be the and when we did the bronchoscopy, we could not see anything beyond the vocal cords. So there was this vocal cords which were completely fused, and there was a small pinhole opening at the end of the posterior end of the vocal cord. So we could not see anything beyond that. So this was the opening which was there at the end of the end of the posterior end of the vocal cords, and this was the subglottic stenosis. So the CT scan showed a long stenosis. So this was the long stenosis. So congenital subglottic stenosis, membranous is common, cartilaginous is rare. This is the only one case I've seen. And acquired is quite common that we see, and you have the common reason being a prolonged intubation. Another common respiratory sound that we hear, this is a 10-month-old male, multiple hospitalizations, respiratory distress, and if you hear very common. So a rattle is a low-pitched moist sound, as if something is bubbling through water, and it's usually seen in subjects who are breathing at very low lung volumes, and it's due to secretions commonly seen in neuromuscular disorders and spastic children. And this was the child. I'm sorry. So again, that was another sound that we hear quite commonly in these children. A 6-month-old male having cold and mild fever for 1 to 3 days, barking, cough, irritable, and if you see this child so this is a croup where we need to be very careful. Commonly, croup is due to viruses. Parainfluenza causes the majority of them. You need to score them, and treatment is by nebulized epinephrine or steroids. So you can give either oral or injectable steroids, or you can give nebulized budesonide. So upper airway sounds usually can be a snuffle or a snort, which originates from the nasal passage or nasopharynx. Acute coryza and chronic could be allergic rhinitis. A snore is the oronasopharyngeal sound, and it's the commonest is the chronic one, which is due to the enlarged tonsils or adenoids. A stridor is an extrathoracic sound. Acutely is a croup, and chronic is a laryngotracheomalacia, and the rattle which we saw is either chronic is neuromuscular disorders, and acute can be seen in acute bronchitis. So this was another 6-month-old male child, afebrile, sudden onset of severe respiratory distress. And this is how the child was breathing. This child had a lot of difficulty in breathing. So initially we thought that whether this child was malingering, but this child was quite sick. And we decided to go ahead and do the bronchoscopy, and we could see a tracheal foreign body. So whenever in doubt, so that's what was said by Dr. Chevalier Jackson, that whenever there is a doubt, let us do the bronchoscopy, because we need to evaluate what the reason for this respiratory distress or abnormal sound is. Because many times with the foreign body, the X-ray can be normal. So it's like tossing a coin, having a wheeze or an abnormal X-ray. It can be normal in 50% and abnormal in the rest 50%. 4-month-old male, fever for 4 days, tachypnea, low SATs, and when we look at so it's a expiratory low pitch sound, some musical character, and it's due to the adduction of the vocal cords, which is done to generate peep. So it is seen in respiratory distress syndrome and pneumonias. So basically what happened is this stethoscope that we use to diagnose and to see these patients is actually taken from the cardiologist. So stethoscopes were not meant for us actually. It's meant for the cardiologist. We have borrowed it from them and we try to detect all these lung sounds. And now that's why a lot of computerization of this lung sound analysis is coming, and uh, we need to amplify selectively some sounds, especially those below 112 hertz, and then attenuate the higher frequencies to come to a diagnosis. So various types of electronic microscopes are now available where you can actually change the modes. So you don't have to go to the diaphragm or the bell mode. You can change them over here and you can auscultate using these. But the problem with this is you need the entire chest piece and the earpiece for this. So various other forms are also available, like this is one form of the electronic stethoscope which you can use, developed by Think Labs. This is another one, and this is the smethoscope, and this is the IuSync. So IuSync also you can use if you connect you can use the earphones over here. You can use it using the Bluetooth. So this is a prototype of the IuSync which you can use, and you can see actually how to so you this is the IuSync. So you have a end over here where you, if you want, you can connect the earpiece, and this is the only the small piece that you have, and you can use it with the Bluetooth. So the beauty about this is, particularly in this COVID situation, when you're wearing the PPE, you don't need to actually take out, so you can use this and you can auscultate using your Bluetooth earphones. So the sound also is magnified. It's magnified to around 16 to 20 times. So it's very easy. And you can actually change between the two sounds. So lung sounds, you want the 50 to 2500 hertz. Normal breath sounds, again, it's around 200, 250. V's, you want 100 to 1000 and crackers. So that's how you can get the detailed respirosonogram. You can record it on your mobile phone. And if you want, you can send it to somebody if you want to get it analyzed. So you see here over here, you can send it to Anirban if you want, and he can tell you what he's seeing. So these are the future directions. So upper airway diagnosis monitoring, particularly the obstructive sleep apneas, the lower airway dynamics, example, asthma, bronchiolitis, assessment of regional ventilation, determining the site of the obstruction, and lower airflow obstruction assessment in very young kids. So all these are the interesting things that can be, it's the future hurdle in this, but it's still expensive because the Think Lab ones cost around 45,000 and the IuSync one costs around 17,000. So it is still expensive, but probably we need to get, we will be getting cheaper ones as more and more such companies come forward. This is developed by the Indian Institute of Technology, Bombay. So like this, more and more upstart companies come forward, and we'll be getting much more cheaper such scopes. And thank you again. Thank you, Apurba. Thank you, ICH, for this opportunity. Thank you very much.
Thank you, Pallab. You're a part of ICH.
Oh, thank you. Thank you.
You're a part of ICH. We get your help every now and then in our PICU when you need to do the bronchoscopy and others. Thank you. For your nice presentation. Our next speaker is Dr. Priti Khemka, young upcoming bride, Priti, who will be talking on respiratory distress in newborn.
Okay, so am I audible well? Hello? Hello? I hope I'm audible well. So without wasting too much time, I'll begin my topic, which is respiratory distress in neonates. So is it tachypnea or respiratory distress? So tachypnea is when the respiratory rate is increased in more than 60 per minute, the normal rate being 40 to 60. And if it's respiratory distress, it is tachypnea along with retractions or grunting. A baby can also have apnea, cyanosis, lethargy, and poor feeding as a manifestation of respiratory distress. So when faced with a baby with respiratory distress, make sure you identify life-threatening signs like apnea, bradycardia, cyanosis, gasping or poor respiratory efforts, or stridor, for which prompt intervention is required. So we'll just quickly go through a few cases. I'll be rushing through my slides as I know it's time for dinner for everybody. So the first case, term baby boy born by section at 38 weeks and has grunting, respiratory rate of 70 and is cyanosed soon after birth. Chest X-ray, as you can see, is showing a streaky sunburst pattern, fluid in the fissures, and a mild pleural effusion can also be seen. So I'm sure all of you have guessed it right. It is transient tachypnea of newborn, which is the most common cause of respiratory distress, usually seen in near-term babies, and it is due to delayed clearance of lung fluid, mostly seen with cesarean sections without labor and maternal diabetes. Tachypnea begins soon after birth or within 2 hours with other signs of distress, and it is a benign self-limited condition and improves by 2 or 3 days. So what are the other causes of respiratory distress besides TTM? Pulmonary causes like RDS, meconium aspiration, pneumonia, pneumothorax, congenital lung cyst, diaphragmatic hernia, choanal atresia, laryngeal web, or polyp. Extrapulmonary causes can also lead to respiratory distress. For example, cardiac causes like congestive heart failure, congenital cardiac problems, CNS causes, neuromuscular causes like asphyxia and SMA, metabolic causes like hypothermia, hypoglycemia, metabolic acidosis, chest wall causes like asphyxiatic thoracic dystrophy, skeletal dysplasia. So in the second case, term baby born after variable deceleration and thick meconium stained lichen. So emergency section was done, baby was covered in meconium. Baby was depressed at birth, heart rate was less than 100 and poor respiratory effort. So the baby was intubated, meconium suction, and then positive pressure ventilation was given. So what do you think went wrong? So resuscitation in presence of meconium stained amniotic fluid, as even as far back as the 6th edition of NRP, if the baby was not vigorous at birth, that is depressed respiration or depressed muscle tone or heart rate less than 100, it was advocated to do direct tracheal suction before giving any positive breath to prevent aspiration of meconium into the lungs. But now, with the new 7th edition of NRP and the recent updates, even in presence of meconium and even after the initial steps, if the baby is not breathing or a heart rate less than 100, it is advocated to proceed to positive pressure ventilation. Routine intubation and meconium suction is no longer advocated. So remember this. So in meconium aspiration, you will see diffuse bilateral course infiltrates, hyperexpanded lung fields, fluffy shadows. Brief discussion on pathophysiology of mass. Meconium aspiration causes mechanical obstruction by meconium, which can lead to air trapping if the obstruction is incomplete, or atelectasis if the obstruction is complete. There is secondary surfactant inactivation as well due to meconium, which can lead to further atelectasis. And meconium also causes chemical inflammation of the lungs, leading to release of vasoactive compounds and leading to PPHN. So the complications of mass, as you can see, is air leak, respiratory failure, and PPHN. So most babies would need oxygen or respiratory support in the form of CPAP or conventional mechanical ventilation. A few babies would, with severe mass would go on to need high frequency ventilation. And as you have seen, there is secondary surfactant inactivation, and babies with severe mass, randomized control trials have shown that surfactant reduces duration of ventilation and need for ECMO, but with no reduction in mortality. So surfactant should be used judiciously in cases of severe mass. Inhaled nitric oxide acts as a selective pulmonary vasodilator and can be used in babies moderate to severe PPHN in mass. And in babies who have persistent oxygenation index more than 40 despite optimum ventilation and inhaled nitric oxide, ECMO is indicated. So moving to the next case, the same baby with mass who was intubated, ventilated, is needing high ventilatory pressures and suddenly deteriorates. Chest is looking asymmetric. Breath sounds are diminished on the right. Transillumination, the resident does a transillumination, requests an urgent X-ray. So as you can see, the chest and the side of the pneumothorax is fluorescing brightly. Make sure the room is dark when you perform this test. Even the vein finder that you use, usually a cold light source is used, but even the vein finder that we have in NICUs nowadays can be used for transillumination of the chest. Now, this is a useful bedside test, and if a pneumothorax is diagnosed, proceed straight to needle thoracocentesis without waiting for the chest X-ray. Anyways, chest X-ray was awaited, and as you can see, there's hyperlucent hemithorax with a collapsed lung margin can be seen, absence of lung margins on this side, and shifting of mediastinum to the opposite side. So what is the other test, bedside test, which can be done in pneumothorax? Nowadays, most neonatal units are equipped with bedside ultrasound machines. And these are few of the signs which can be helpful in diagnosing pneumothorax. Lungs, which I'll explain in the subsequent slides. Lung sliding will be absent. Lung pulse, which is due to transmitted cardiac pulsations, will be absent. B lines will be absent. If B lines are present, it rules out pneumothorax. The lung point will be present, a point where the seashore sign will change to a stratosphere sign. And on the M mode, the stratosphere sign will be seen. That is only the C and no shore. Now, if you look at this video of a normal lung, you can see lung sliding. This is the pleura, and these are the A lines. You can see the lung sliding. And in the next video, if you pay attention with pneumothorax, you will not be able to see the lung sliding. And on the beam, on the M mode, a normal lung will give the seashore sign. The pleura and the superficial structures is the sea, and the lung parenchyma is the sand, and you have the seashore sign. And with the pneumothorax, the pleura and the lung are separated, so you will be seeing only the sea, stratosphere sign, and no shore, stratosphere sign. Now, so pneumothorax, if the pleural line and A line are present and the lung sliding is absent, it is suggestive of pneumothorax. B lines should not be present. If present, pneumothorax is excluded. And on the M mode, the stratosphere sign will be seen and it diagnoses pneumothorax. But if you see the sea beach sign, sandy beach sign, pneumothorax is excluded. Risk factors are used, as you have seen in this case, mechanical ventilation, meconium aspiration, pneumonia, RDS. But with the advent of surfactant, incidence of air leaks has reduced. But even after giving surfactant, lung compliance improves, and if ventilation is not weaned appropriately, it can lead to pneumothorax. Even spontaneous pneumothorax can be seen in up to 1% of term babies. So management, if asymptomatic close observation and it will resolve in 48 to 72 hours, small pneumothorax may sometimes resolve with just needle thoracocentesis. But if the baby is ventilated, intercostal tube drainage will be required. For a hemodynamically unstable baby, immediate needle thoracocentesis should be done in the second intercostal space, mid-clavicular line on the side of pneumothorax. In our country, pigtail catheters are not easily available, but where available, they are preferred because they're faster, less traumatic, and easier to insert. Now, so next case is a 28-weeker born following a placental abruption, has not received antenatal steroids, given positive pressure ventilation, but develops respiratory distress soon after birth. So as you can see, the chest X-ray shows diffuse reticulogranular pattern or ground plus pattern, air bronchogram, and low volume lungs. So respiratory distress syndrome, which was previously known as hyaline membrane disease, and it is seen primarily in premature infants. And incidence is inversely related to gestational age and birth weight. This is a disorder of surfactant deficiency, and surfactant, as you know, reduces alveolar self-extension and prevents collapse of alveoli during expiration. I won't be discussing the management of RDS, but I'll just, this is a good read. If you, the European Consensus Guidelines on the Management of Respiratory Distress Syndrome, the 2019 update, they come with recommendations, updates every few years, and please go through them. I'll just mention a few points from the European Consensus Guidelines. So antenatal steroids should be given to all women at risk of preterm delivery from when pregnancy is considered potentially viable until 34 weeks and ideally at least 24 hours before birth. And max self should be given before 32 weeks gestation. CPAP is recommended from birth at all babies at risk of RDS less than 30 weeks who are not needing intubation for stabilization. So that is delivery room CPAP. And if CPAP with early rescue surfactant is considered optimal management. So just CPAP is enough, but if baby is requiring more than 30% oxygen with a CPAP of at least 6, early rescue surfactant is recommended. Now, LISA is the preferred mode of surfactant administration for spontaneously breathing babies on CPAP, provided clinicians are experienced with this technique. Our unit has adopted the LISA protocol and is routinely doing LISA for preterm babies. You're all familiar with the Ensure technique, but newer modes of surfactant administration like LISA, MIST, LMA have come into being. So LISA is where, or LISA or less invasive surfactant administration is where a thin catheter is used to deliver surfactant in spontaneously breathing preterm babies with RDS receiving non-invasive respiratory support. So a LISA has shown in randomized control trials to have less death or BPD and less need for mechanical ventilation compared to babies who received Ensure. So the next case, term baby with meconium stained liquor develops respiratory distress and the CRP has gone up. So post heterogeneous infiltrates can be seen bilaterally, and the differential diagnosis, would be meconium aspiration syndrome or congenital pneumonia. So congenital and postnatal pneumonia, they can also manifest with apneas as well as respiratory distress. Common pathogens in the West are group B strep, but in our country, Klebsiella, E. coli, and other gram-negative pathogens are more common. Risk factors would be prolonged rupture more than 24 hours, prolonged delivery, maternal fever, chest x-rays, non-specific, bilateral infiltrates, and supportive care, antibiotics, and respiratory support. The next case. So a term baby boy born by section presented at 12 hours with excessive drooling of saliva. He had also developed respiratory distress after feeding. There's a history of polyhydramnios, and the feeding tube could not be inserted beyond 10 centimeters. So the X-ray was done, and you can see the feeding tube coiled in the upper esophageal pouch, suggestive of esophageal atresia. And a stomach bubble can be seen, suggestive of distal tracheoesophageal fistula. If the stomach bubble is absent and the abdomen is scaphoid, it is suggestive of proximal tracheoesophageal fistula. So esophageal atresia with tracheoesophageal fistula, it's a congenital anomaly with blind ending esophagus, which may be associated with a fistula between the abnormal esophagus and trachea. 85% cases of esophageal atresia are associated with tracheoesophageal fistula. Suspect if the antenatal scans are showing polyhydramnios with or without absent stomach bubble. And as mentioned previously, if there is a proximal fistula, the stomach bubble will be absent. Babies will present with frothing at mouth and respiratory symptoms on feeding, and there'll be difficulty in passing nasogastric tube. So if you have a baby with esophageal atresia, examine for the other components of Bacteria as well. Diagnosis is confirmed by inability to pass a feeding tube from the mouth or nose into the stomach. Typically, resistance will be felt at 10 to 12 centimeters from the nostril. When an X-ray will be done, the feeding tube will be curled in the upper esophagus, and the gastric air bubble, if seen, confirms presence of fistula between trachea and distal esophagus. So management, nurse the baby head up and turn to the side to prevent aspiration of secretions. If Replogal is available, it's placed and a continuous suction is done. Replogal or the multiple end-hole suction catheter is not easily available, and an NG tube is placed, which is aspirated every 15 minutes. Positive pressure ventilation should be avoided, but if intubated, keep the ET tube close to the carina to minimize gas flow through the fistula. Unless there's a long gap, which is a challenging problem, a primary anastomosis of the proximal and distal ends of esophagus is done, and the fistula is divided. So what are the other surgical disorders which present with respiratory distress besides esophageal atresia? Diaphragmatic hernia, choanal atresia, congenital lobar emphysema, CCAM, or what is called CPAM now, pulmonary sequestration. So without even describing the case history, if you look at the chest and look at the abdomen, I'm sure you'll notice that the abdomen looks scaphoid and a diagnosis. And with this chest X-ray, with the bowel loops in the chest and mediastinum shifting to the right, a diagnosis of congenital diaphragmatic hernia is made. And you all know that most of the defects on the left, with the defect in the diaphragm being posterior. And note there is lung hypoplasia on the affected side as well, but the contralateral lung is also affected due to mediastinal shifting. So last case, this baby presents, a 2 days old baby presenting with tachypnea, mild recessions, and is lethargic. He's poorly perfused and femorals are feeble. So a duct-dependent critical congenital heart disease was suspected. He was started on prostaglandin. Cardiac review was requested on echo. Coarctation was seen. So the differential diagnosis of this condition would be a duct-dependent systemic circulation like coarctation, critical aortic stenosis, or hypoplastic left heart syndrome. Duct-dependent circulation like pulmonary atresia, critical pulmonary stenosis, tricuspid atresia, TOF, and duct-dependent systemic and pulmonary circulation like transposition of the great arteries. Other potential diagnoses, as you see, PPHN, lung disorder, sepsis, metabolic disorders, and methemoglobinemia. So how would we distinguish cardiac versus pulmonary? In cardiac problems, retractions will be absent or minimal, will be marked in pulmonary problems. Grunting will be absent. Cyanosis will be severe in cyanotic congenital heart disease and will not improve with oxygen, whereas in pulmonary causes, it will be mild and improve with oxygen. Hepatomegaly may or may not be present with cardiac problems. And on auscultation, you may or may not hear a murmur. Chest X-ray, the cardiac size will be abnormal and pulmonary parenchyma mostly normal. And on pulmonary, you can see some pulmonary shadows. Blood gas, the CO2 is usually normal, whereas in pulmonary causes, CO2 is usually high. So the CDC recommends routine pulse oximetry for screening for critical congenital heart disease, where pulse oximeter is placed on the right hand and 1 foot around 24 hours of age or earlier being discharged. If the saturation is more than 95% in the right hand and foot and less than 3% difference, the baby passes the screen. And if the saturation less than 89% in either right hand or foot, immediate assessment is required. If the pulse oximetry reading is 90 to 94% either right hand or foot, or difference of more than 4% in the right hand and foot, repeat the assessment in 1 hour. And if the saturation is less than 94%, either the right hand or foot, or more than 4% difference, immediate assessment is required. So key messages: respiratory distress is an important cause of neonatal morbidity, mortality. TTN is the commonest causes, but exclude other causes as well. Other than TTN, chest X-ray and septic screen will be needed in most cases of distress. Ventilatory support and good nursing care can improve outcome. Thank you.
Very good, Priti.
Thank you, sir.
Nice presentation. But I think you should have covered a little bit of metabolic diseases presenting as respiratory distress.
Stop sharing.
You should have included a little bit of metabolic disease presenting as respiratory distress.
So that is your field.
No, not that.
But every
you know, when we see a patient with respiratory distress, we think of lung cause, we think of cardiac cause, but what we miss sometimes is that the metabolic cause. Central causes we do think of because it's very irregular. As a whole, looking at the baby, you can think of that this might be a central cause. But metabolic causes are very easy to miss. And thank you. Thank you, everybody. And most importantly, Somnath. You have done a great job. Thank you. I mean, it's too late now. Thank you, Priti.
Thank you, sir.
Thank you, all the participants, audience, everybody.